Hello, my name's Gillian and I'm a registered nurse and lead auditor and Director of Healthcare Compliance Solutions. We specialise in working with aged care services across New Zealand. In this session today, I'm going to go over the concepts of clinical documentation as they apply to long-term care aged residential care. So let's work through this presentation. If I can get that to go to the next screen, there we go. Aim of this workshop, we're going to cover the purpose of documentation, and when I talk about documentation, I'm also referring to electronic and digital, not just when you get your piece of paper out and your pen, and the types of documentation and the legal implications, excuse me, how documentation aids service, why we actually document to the extent that we do, what the contractual and legislative requirements are. So, purpose of documentation, whenever we record anything in a clinical setting, it helps structure communication between staff. It helps relay specific information, and that information may be specific to the care plan of a person, but it is certainly specific to an individual. We talk about person-centered care, and so we're looking at how our information that we're recording relates to the person that we are caring for, what their needs are, what we're assisting with, what their level of function is, what the changes in their presentation is, and any changes in the treatment plan. So we're looking at a whole range of information. We're recording the progress. That's why we call nursing notes progress notes. All allied health doctors, everybody that's involved in the multidisciplinary team for caring for or nursing, looking after a person's clinical needs, is going to be writing progress notes to record the level of progress against the desired outcomes. And those desired outcomes, as I'll explain a little bit further on in this presentation, are noted in the long-term care plans. So we record the plan, that is the long-term care plan. We look at assessment. We can't possibly plan until we've assessed to determine what needs are. And of course, it is about accountability as well. That's why whenever we record anything or note anything down, it always should have the name, or must have the name of the person who has recorded the information or noted it down, written into the computer, whichever format we're doing it in, the designation of that person, and also the date and time that that occurred. The legal evidence of service is also what we use our documentation for. If there is a complaint or an investigation into care, then it's the written information, the documentation, the electronic record that is looked at to determine what actually happened and the time frames and the sequence and who was involved when. So it's important that all of that detail is being recorded. So if you look at your documentation, if somebody else looks at your documentation, is it going to protect you in a case of allegations from others? Do you have professional indemnity insurance as a nurse? Yes, you should have. As a health professional, yes, you should have, because things go wrong. They shouldn't, and we do our best, but sometimes they do, and sometimes you have to justify yourself, and to have somebody backing you and professional indemnity insurance to give you that sense of safety will also be advisable. So common types of documents, we've got a whole range of different documents or pieces of information that we record on. Some of those relate to admission, and when we're doing the admission, remember that planning is everything. If we can start the admission process before the day of admission, even better. Start collecting information about the resident, about what their needs are, so you start to get a sense of how to prepare for the person's admission into your service so that you can adequately and appropriately meet their needs. So then you've got initial assessment and short-term care planning for any acute issues, things that are present on the day of admission or in those early periods of the first 24 hours Specifically, you're looking at putting in a short-term care place for anything that is evident at the time of arrival. So if they are admitted into your service and it's evident that they have uncontrolled pain, then you should be writing a short-term care plan to manage that. Clinical assessments, and we'll talk about a range of those shortly, the care planning and progress notes. If you have a look at your DHB funding contract, the age-related residential care funding contract in section D16.3, as noted there on the PowerPoint, that's the area that talks about care planning and progress notes. And if you haven't seen a copy of the funding contract, if you are subscribing to the HCSL services, then the document library in the online system that you use will have a copy of the latest funding contract there. Go to section D and have a look at that. For nurses, for care staff, that's the area particularly that relates to the service specifications around how and what is required from you, in addition to the standards and evidence-based nursing practice. So we've got those short-term care plans. You're going to do them for acute issues. You're going to do them for things like an infection. Even if you do a medication change, how do you know the effectiveness of that medication? So if you do a short-term care plan, put the medication change in place, monitor the changes in symptoms, how symptoms are presenting in relation to the change in medication, and then you can get to a point of evaluation to determine if that change was actually effective in what you were trying to achieve, or what you and the doctor or the nurse practitioner were trying to achieve with this resident. Drug medication sign-off sheets, and remember now that we also have not just the pieces of paper that we sign off on for every administration of medication in accordance with policy and procedure, but also the electronic systems, making sure that they are being completed fully. Referrals, another type of documentation, making sure that referrals to a dietitian if there's unintentional weight loss, or to a wound care specialist, or anybody else that you want a higher level of detailed assessment for a resident, make sure that those referrals are filled out comprehensively so they know exactly what's happening and exactly why you're making the referral, and send those through in a timely way with your details, your name, your signature, and your designation, and of course the date. So we have other documents in aged residential care. We have mission agreements, resident registers. Now with HCSL, once again, those of you subscribing, especially on the new software that's come out at the end of 2019, 2020, you'll find the resident register is no longer no longer a paper version, but is an online version. Adverse event reporting forms, infection reporting logs, those sorts of things are all written into the software as well. Excuse me, but if you're not using that, you would be expected to have a paper trail for all of these things, including your complaints, your complaint management process, your training records, the evidence training, what was included in training, how long it went for, who the person was, and what their credibility to actually provide that education was. Internal audits, you're looking at internal audits and the outcomes of those internal audits. Once again, in the document library for the HCSL system, they are in the document library as a paper version you can print out, or they are directly into the software, so you can go around your site with a tablet and fill those out. If you're filling them out online into the electronic system, it will automatically put corrective actions where there are gaps in service identified in those internal audits. Those corrective actions will go directly into your corrective action log for you to manage there. And of course, minutes of meetings are another way of evidencing the discussion that went on, the planning that you have in place, the things that are issues, and how you are addressing those as you go along. Legalities, now I've already mentioned legislation, I've already mentioned funding contracts and service specifications and standards. Make sure that all of your documentation is factual, legible. If you're electronically signing in, it will automatically note your name as per your individual login. But once again, use your individual login. Do not be using other people's logins, and make sure that when you have finished your notation into an electronic system, that you log out. Make sure that you are writing in a way that is non-judgmental, and only use abbreviations that are specific to your site as per your approved abbreviation list. If you're using paper, use black or blue ink and don't leave blank lines, and don't use whiteout or highlighter. Sorry, I went too quickly there. With your electronic system, it makes sure that you're not able to do those things. So as I say, it depends on whether you're using paper or software to record your information. Either way, the rules and regulations are the same. Think of writing into software the same as you would for writing on a piece of paper, whether it be a progress note or a short-term care plan, a long-term care plan, etc. Now, I mentioned the document library. If we look over here, this is the document library in the purple area here. The internal audits are here, and the corrective action log is here. Your resident files, of course, and the more button over here to give you access to the initial care plan, the long-term care plan, and to create reports is all there sitting for you online, keeping everything all in one place together. Now, we have uploaded into your document library copies of the standards as they apply to you. So looking at initial assessments a little bit further, initial short-term care plans, I've talked about those in relation to admission. Please note who is involved in giving the information at the point of admission. Make sure that as much as you can, it's credible information. Sometimes you are going to have limited information for an admission if they haven't had somebody living with them, if they've come from the hospital, if their family are not available. It may be that there are gaps in that initial information. So remember that the presentation of that resident as they settle into your service from day 1 through to day 21, those first few weeks and even longer, is going to change how they present as they settle in and start to get familiar with some of the faces that they might see on a regular basis. Hopefully they're seeing regular faces and not a constant change. That's one of the joys of long-term care, that continuity and relationship that's able to be formed in this therapeutic way. Initial care plan, that is a copy of a paper version, and once again the ICP is the initial care plan is written into the software. Clinical assessments on the day of admission, you'll be starting your initial assessments, and those are built into the initial care plan process online. But you will also have the INTERI, the mandated INTERI National Clinical Assessment Tool, to be collecting further information from usually about day 4, once people have started to settle in. And you're going to use that information to form the basis of the long-term care plan. And it's then going to be used to inform residents' care. And you can see there that once again, I've referenced the ARC contract where it specifies the mandated use of INTERI clinical assessments in long-term care in New Zealand. Care planning, these must be developed by a registered nurse, or there is some capacity for the later scope of enrolled nurses to be involved in some care planning with oversight by a registered nurse. So nursing process hasn't changed over the years, it's still the same. We want the nursing diagnosis. What's the deficiency? And deficiency isn't actually a very nice word. What is the need that the person has? What's the gap in their ability to self-care or self-manage? What is the clinical need that we are trying to meet? So once we identify that, we can then identify the goal or objective, or what it is that we're trying to achieve in relation to this nursing diagnosis. And make sure that that objective is noted in a measurable way. The interventions, this is for the staff to implement the care plan. to achieve the goal. So these are the instructions for staff to make sure that they are implementing everything in a detailed way to meet the outcome for the resident and make sure that we are supporting them to meet those things that they can't do for themselves. The initial care plan through to the long-term care plan. Use that initial care plan for that first 24 hours, the first day of admission, to start getting information, and as you progress from about day 4, as I said, use the inter-eye and use the scores from the inter-eye assessment to populate into and inform how you develop the long-term care plan. If you find that completing the inter-eye assessment doesn't give you sufficient information, then you can do additional assessments, but make them relevant to the presentation, the diagnoses, and the information you have about the resident. There is no point really in my mind doing a continence assessment for somebody that has come into care that is cognitively intact, that is able to tell you coherently that they don't have any issues with incontinence, that they are fully continent, they're able to self-manage. There's no sign of any incontinence, there's no wet beds, there's no wet underwear or soiled underwear, there's no smell that would give you indication. Use your senses to do those assessment processes. And if that's the case, then don't spend time doing a continence assessment where it doesn't appear that it's actually relevant. If, however, the person is noting pain, they appear to be in pain, they're slow in their movement, or they have a facial expression that indicates discomfort as they're moving or trying to do something, then yes, do further pain assessments. Dig and delve into that. What has helped with their pain before? What's been used before? What's been successful? What hasn't? And make sure that all of those things are noted down in the care plan so that the staff have good information to base the care on. So follow up on acute presentation and make sure that there's regular input in the progress notes. When we talk about progress notes, there should be a notation in the progress notes for every resident on every shift, regardless of whether they are rest home level of care or hospital level of care, being the two main designations of care. So if we look at a couple of short-term care issues, for example, here we have weight loss. Unintentional weight loss is something that's quite common. Unmanaged pain is also something that's quite common, unfortunately, and needs managing. So if we look at these two examples, we've also got one of infection, so a urinary tract infection. Always start with the policy. If you're not sure, what does your policy say? There is good, clear guidance in your policies and procedures to support a consistent process for working through these clinical issues. Look at how you're weighing. Are you weighing consistently? Are you making sure that when you're logging a weight for a person that you are noting it on the in a consistent way so that the date is relevant? If I say that in the care plan that there is a monthly weigh and there is a weight on the 26th of February and the next weight is the 3rd of March, then there's not a month between those two dates. Make sure you're not just putting February and March. Please put the full date. And if you're writing the year, you should be putting 2020 as well as a full date. So make sure that the weight is being done consistently. Is it always first thing in the morning on a Monday morning, on the 4th Monday morning of the month with the person fully dressed? Or, make sure that you get that consistency. Food and fluid intake charts, once again, make sure that they are detailed so that the information is able to be measured. If you say eat well, that might mean something completely different to each one of you. So if you have a look at the measurement and think of it in an objective way so that you can measure that object or the amount of food. Is it half a piece of toast? Is it half a cup of soup? Is it 150 mils of soup? Measure it. Is it 2 teaspoons of porridge? Put that in. That's much more meaningful. The more detail, the more we're able to gain a clear picture of exactly what the intake is. Make sure nurses that where you've got care staff filling out monitoring forms and intake forms and various other forms for assessment purposes, that you are following up and checking that not only are they completed, but what does the information tell you? If you're looking at a food and fluid intake chart and it says that the person has only had 250 mils of fluid in the last 12 hours, as a nurse, unless it's contraindicated medically, then you would know that that's not enough. And you would then have to address that with your staff and make sure that there are other mechanisms put in place to increase fluid intake. Note the staff input and assistance, the RN review process there, and of course referrals. When you are not getting the outcome that you desire, short-term care plans should be evaluated at the most every 7 days. That's just a guideline. It's not mandated, it's not legislated, but good nursing practice. Don't let it go beyond 7 days without doing an evaluation and looking to see, are you on track? Are you progressing in the direction that is a gain for this resident? Infections, once again, if you're managing a short-term care plan for something like a urinary tract infection, once again, if you're unsure, look at the policy and procedure, look at the presentation of symptoms. What are the associated symptoms? Is pain being managed? Are the interventions being implemented? There should be evidence in the progress notes by the care staff, by the healthcare assistants, and physio aides and anybody else that's having input into care, evidencing in the progress notes that the interventions of the care plan are actually being implemented. That means that the staff need to look at the long-term care plan. If they haven't looked at it, they can't possibly making notes about how it was implemented. Here's another example, wound and skin care, making sure that you are putting measurements in place and being very clear in your descriptions. I've certainly, as an auditor, been into care facilities where they have presented me with a person that was designated as responsibility for wound care management, or the wound care nurse, and I've asked how many treatments they currently are managing, and they haven't known. And I've asked how many pressure injuries there are on site, and I get inconsistent answers depending on who I speak to. So make sure that this information is clear, that it's accurate, and it's consistent and available to everybody. So it doesn't matter which nurse I ask, if they are managing that group of residents, they should know what's happening with them. In the care planning process, as I say before, your progress should be noting what the healing is, as well as how you are achieving the goals of the care plan. Are you clearly tracking progress? Are you taking photographs? In HCSL Wound Care Plan and the later version of the software, you can certainly be doing all of the wound care management online, including uploading the photos. So verify assessment at each time you do a dressing change. And once again, that can be noted either on paper form or directly into the software. Care plan evaluations, as I've said, they must be measurable so that you can determine have you achieved them or not. Interim reassessment for change of level. As people go through trajectory of care, or their needs change over time, we need to make sure that reassessment is occurring. So this is what the ARC contract, the DHB funding contract says, that they will review the reassessment and provide you, the care facility, with the outcome of the review no later than 5 working days after you provide the reassessment to the NASC service. So that's the Needs Assessment Service Coordination service in your region. So that's what's actually in the ARC contract. If that's not happening and those assessments or reassessments are coming through later than that, you might like to gently remind them. I know that this is often a resourcing issue, but it is important that people are being reassessed and that they are getting the level of care that they need for their presentation. All right, so you can see there are various timeframes and requirements written into fund contracts. Opinions when you're writing progress notes are not generally accepted in courts, nor is hearsay. If you did not see, hear, feel, smell, or taste, and please, in a clinical setting, do not go tasting things other than your own food, which has been securely wrapped and you know it's yours and hasn't been touched by anybody else. Oh dear, anyway, we rant over. But wish to report the occurrence, state your source. So in other words, if you go off duty and you forget something, you can ring in, speak to the nurse on duty and say, would you please write in the resident's notes, be very specific about who it is. You can ask them to write on your behalf and they must say, as relayed by you, and put your full name and your designation and how they got that information via phone call or whatever it was, so that they can note the source of the information. Otherwise, you can get in your car and come back and write that in yourself as an addition or an afternote, all right, and then reference to the time that it related to and the date that it related to. If it was a note that you are making after the actual event and outside of the general sequence of notes. So when to write in progress notes, as I mentioned before, if we're not writing in them very often, then how can we evidence that we are providing shift by shift care? Written records must give a clear indication of appropriate and timely service. So the health record standards, which is New Zealand Standards 8153, health professionals should document as frequently as indicated by the clinical condition of the patient or client or a long-term care resident. They should document each patient-client contact in the health record or one entry per shift. All right, so it's either per evidence of, no, I'm mumbling here and going around in circles. So it's about evidencing the care that you're providing. So if it's an episode of care, then you should be noting that. If it's a change, something that's happened during the shift, you should be noting that. But at least somebody from your care or nursing team should be writing at least once a shift, okay, for each contact or once a shift. Subjective, objective, subjective information. Don't worry about this too much as long as we're getting clear indication of where we're at from a progress point of view. The subjective information is what the resident or their visitor, family, whānau have said, the expressions of what they felt or they thought. The objective information, and how I always used to remember that as a nursing student, was an object can be measured. When you find something that you can measure, that's the objective information. So you can put clear signs, measurements. You can say how big the bruising is, the extent of the swelling, the amount of ooze, TPR charting, weight, blood glucose levels or blood sugar levels. Those things are certainly a number measurement. So those are objective pieces of information. The idea is to get both. So collectively, you're getting a broad picture. George, sometimes I have people say to me, but, we've got George, for example, that's in residential care and he really doesn't change from day to day. He may not on the outside, but there are different things that happen. If George starts his day like this every day, that's how he is when he comes on shift. Is he still like that when you go home at the end of your shift? I would hope not. And certainly in between, something has happened. Has he got up? Have you assisted him to get up? Did he use equipment to get up? What was his level of function compared with what it was last time you were involved with his care? What was the level of assistance? Is he normally self-feeding, whereas today you had to help assist him more with his food intake? Look at those finer details in your clinical documentation and report writing policy. Those supplied by HCSL, you will see quite clearly a progress note writing guideline in there to give you lots of hints and tips on the sorts of things that you can write when your mind goes blank and you think, there's nothing new to write. There always is. All right, as I've said, make sure that your notes are clear and that they are timely. The doctor's job is to diagnose, so we can't say in our progress notes that somebody appears depressed. Depressed is actually a diagnosis, but what we can say is what makes us think that. As nurses, we can come to conclusions, but there are signs and symptoms that help us get to that conclusion, which means that those are the things that we raise with the doctor for medical input and treatment planning, or with the nurse practitioner. So instead of saying that the person appears depressed, we can say that they appear more withdrawn, that they might have loss of appetite, that they've been tearful when normally they're more engaging and enjoy their social activities. So once again, look at the changes that are happening and record those. Your role as a nurse or healthcare assistant is to be involved in assessment, monitoring, providing that nursing care, evaluating nursing care for the registered nurses, and ensuring that the interventions are consistent with the care plan. Delegation by registered nurses is defined in guidelines by Nursing Council. You can go to the Nursing Council website and you will find those delegation guidelines. Once again, we have put copies of those in the HCSL document library online for you so that everything is there. Make sure that you are liaising with other health professionals in relation to each resident, so you're case managing collectively together to get the best outcomes for them. Medication and order sheets or electronic charting, we can have e-charting these days. Make sure that everything is signed off as it should be if you are still working on a paper-based system. All right, and you must not be transcribing. Once again, the medication policy provided by HCSL has definitions for what transcribing is. And of course, we are doing away with faxes, thankfully, because they are certainly a minefield of potential errors. We have all sorts of clinical resources. We've loaded a number of them into the document library, the frailty guidelines, for example, and here are a number of other sources for you. Make sure that if you are accessing information online, it's from a credible, evidence-based site. Wikipedia or general Google searches of non-academic or non-evidence-based sites should not be used to help guide clinical care. All right, once again, you can see there are a range of different New Zealand-based sites for you to look at. And finally, yes, sometimes we get it wrong. One patient states that he's feeling much better since he stopped drinking and going to church. Well, I suspect that somewhere there should be a full stop in there, somewhere after drinking, and then going to church is something that's making him feel better as opposed to not. Drinking good amounts of urine, sadly, I have had a patient in the past that did do that. In the old days where we had catheter bags with the outlet on the end of it, and if we weren't careful, he would recycle the contents of that into his fluid jug beside the bed. And so we need to be very careful about how we word things. Shortness of breath on excretion, yes, that's probably true in some cases, but I think it means shortness of breath on exertion. On the second day, the knee was better, and on the third day, it disappeared. Now, I understand that English is a second language for a lot of staff that are having to document in clinical records, and sometimes the syntax or the order of words is hard to get right when we're translating from one language to another. As a child, I grew up overseas. I was born in New Zealand but grew up overseas and have been multilingual, and so I do get that. I understand that, and it's not always easy, and sometimes the brain might translate in your mother tongue and then have to translate back into English, so you're doing a double conversion. And I know, speaking to a lot of staff, that that's exactly what they're doing. So sometimes our documentation doesn't quite end up reading the way we want it to. I'm sure the knee didn't disappear on the third day. I'm sure it was probably more related to the pain. So if you have any doubts about what your document actually says, read it out loud. Reading it out loud, you're actually more inclined to read the words that are actually there than what you think is there. All right, occasional, constant, infrequent headaches. Now, these are actually from progress notes, these bloopers, and occasional and constant are slightly opposing. Well, they are opposing. Constant and infrequent are also opposing, so it's very hard to understand exactly what the frequency of these headaches are. We haven't got description about the intensity or the impact on the person, where the headache is actually centered or anything like that. So once again, just be careful about how you're documenting and the sorts of information that you're trying to relay. If you're writing up something that is a very serious event, an adverse event or very serious clinical event, and it's complex, it might pay to get somebody else to read your notes as well, and in that instance they can help guide you. All right, so my name's Gillian Robinson. We have come to the end of this session. I hope that this has been useful for you. And if you have any questions, you can Google me on Healthcare Compliance Solutions Limited and send us through an email via the contact us on www.hcsl.co.nz.